The next case is 40-year-old female with distal common bile duct and pancreatic duct stricture. The patient presented with painless jaundice. CT scan revealed stenosis of distal common bile duct and the main pancreatic duct. The patient was scheduled for ERAS. We give the floor to Dr. Fukami in the endoscopy room.
Oh, thank you for coming. So this case was 48 years old who came in with asymptomatic jaundice, no abdominal pain. She's known to have alcohol history, 1 liter of beer every day until she gets jaundiced. And she stopped the alcohol when she presented to the other hospital. And liver enzyme gradually faded to normal. As you saw in the imaging studies, the bile duct was dilated, pancreas duct was dilated, almost mimicking a double duct sign. So it's concerning for any tumor in the pancreas head. But MRCP showed rather narrowed distal bile duct. It's much more smooth tapering, and spontaneous normalization of liver enzymes can potentially suggest this may be a benign process. The team here checked the IgG4, which was in normal range, and CA19-9 was normal. DuPont was a little bit high, elevated, but we don't know truly what that really means. So the first step was EUS. I agree with the physicians here. We have to see what type of the changes the pancreas parenchyma has in the pancreas duct, whether pancreas duct penetrating sign can be seen, which signifies the inflammatory process, then tumor process. She does not have a pancreas cancer history in the family. She does not smoke, so the risk factor is not that quite high. So in general, I start with linear convex US echo endoscope. I'm sorry, I forgot to introduce Dr. Stefan Zewald from Switzerland. Also, I want to ask his opinion as well. This is a rather difficult case. I'm using a Olympus system with the ME2 with the Premier line, which has elastography and tissue harmonic echo. And combination of Olympus scope with the ME2 is fantastic. Actually, I'm doing a tissue harmonic echo from beginning to the end. That gives me a really detailed image. So what you're seeing is pancreas focus tissue harmonic echo. And I'm looking at the celiac axis, and I can follow to the hepatic artery to the splenic artery takeoff here. But let's come back and push down to the endoscope a little bit further down. You see SMA takeoff at the deeper site. And then between the echo transducer to the aorta is the pancreas body. Now this pancreas body shows not much of the pancreas parenchymal change. There's some stranding you can see, but there's no there's the calcification. The pancreas duct is let's measure the pancreas duct with this ruler. The pancreas duct is about 2.5, which is slightly prominent, but it's not hugely dilated.
What do you think in the lower part of the pancreas? There are some areas now which are a little bit more echo-rich, and you have such shadows. What would you think
Lower
about
side,
this?
you mean the pancreas body and upstream, or the lower side?
In the image of the
image around
yes,
here.
Yeah.
Yeah, some.
Below the pancreatic duct.
Sorry. I think that I agree with you. There's some increased septum stranding, but there's no hyperechoic foci. So this could be a result of chronic alcohol use. I don't want to say her age is old, but age-related change is another thing. Would you think of anything else?
Yeah, I was thinking now a little bit if there are still, when you are very slowly, if there are still, if there are some calcifications there, because always there's always shadows in the area
Right here.
here, right there.
So Stefan is maybe pointing out some
Yeah.
of the hyperechoic foci with the echopoor posterior shadow. Maybe signifies pancreas duct, pancreas parenchymal calcification. I'm not so totally on it, but let's keep that
Let's
in
check.
mind.
Yes,
Yep.
yes.
But there's no lobularity per se. The pancreas, the capsule you can see is very smooth. Outlining of the pancreas body to tail seem to be rather benign. So let's focus on what's going on in the genu to the head. Thank you. As always, EH is much more exciting. So I put an image up there. This is a transition zone coming from pancreas body to the left side is pancreas head. The pancreas duct is much more prominently dilated, 4.7 millimeter. This must be up to 2 millimeters in a normal range. Now, Stefan has been pointing out these ductal wall is actually a little more hyperechoic, maybe as an inflammatory change. So it's sort of we accumulating evidence that she may have changes of chronic insult, maybe getting into the chronic pancreatitis, although we have not had conclusive criteria yet. So these are maybe chronic alcohol consumption is contributing to those changes.
Norio, what do you think about the pancreas? Is there atrophy or no atrophy?
Good point. So far we haven't seen significant atrophy of the pancreas gland itself. So we saw some of the fibrotic change, ductal wall thickening, but pancreas parenchyma itself is rather healthy. So
Dr.
there's no
Fukami?
atrophy. Yes.
If you see any transition zone
Yep.
at the pancreatic duct, are you going to proceed with FNA?
Yes. So if I cannot confirm the duct penetrating sign, then I
Yes.
think we have to investigate with FNA.
Okay.
The image negative for mass lesion does not exclude the pancreas cancer. On the contrast CT scan, isodense pancreas cancer can be present in about 10% of time. So ductal change is much more important than just seeing the mass.
Right. But what if you don't see any discrete mass on US?
That's a good point. So we have been keep looking at this area. So this is a transition zone from the pancreas genu to the head, and duct is actually disappearing and disappears. Now what we see is much more the scattered hyperechoic areas, foci, without clear mass. So this is a little confusing picture. You hit the point. Now we're not seeing a clear mass, but there's a clearly duct obstruction of the pancreas duct here in the pancreas head. So the question is this changes from pancreatitis? She didn't have any feature of pancreatitis. Pancreas enzymes has been normal. Abnormal pain is absent. So it's getting a little more concerning for more of a neoplastic process. The pancreas duct, bile duct system is actually normal, except that a little bit dilated proximal extrahepatic duct. I'm trying to show it. This is infundibulum of the gallbladder. And actually, gallbladder did not contain any stones or wall thickening. The gallbladder size is normal. And incidental finding is the cystic structures within the wall of duodenum. And if you do the Doppler flow, there's no flow. So this is not the engorged vessels, such as duodenal varices. Nowadays, Doppler is very sensitive. You can see the flow within the wall, within the venous structures as well. So this gotta be cystic change within the wall. Could be lymphangiectasia. And we don't know exactly why it's present in this area. So once we finish the long position, I'll make a short position and scanning from the distal end of the pancreas head. And first try to identify the ampulla, carefully rotating right and left. Here's duodenum going into the third portion from the second portion. And typically you torque towards the back and you start to see normal pancreas duct. It's very tiny. So this pancreas head near the ampulla is actually normal up to here. And if you torque more to the left, you start to see the bile duct here. If I torque more to the left, I'm going to lose the position. So I'm going to keep scanning a pancreas itself. You can see the pancreas, main pancreas duct, duct of Wolfgang, and try to scan through here. So this area is a little more engorged, sort of say. It's a little more enlarged, and the structure, ductal structure, is missing.
I think this is a very interesting case. Norio also explained that this area is for sure suspicious for a lesion. But I think in this case, the history of the patient is also very important. The patient said she had jaundice, and then the jaundice disappeared. And we were discussing this before. I think this is a very important point also, that these features may be also part of a focal pancreatitis. But for sure, this situation we have to count as a suspicious lesion.
Right.
For the moment.
Yep. So as clearly stated by Stefan, we have some suspicion of possibly benign process here, but fine needle aspiration would be proper thing to do. So I want to have more of a core tissue than just the cellular material. Nowadays, there are several companies trying to get more of a core tissue rather than just the FNA samples. One of the needle is, can you show? The Boston came up with the Acquire needle, which has 3 prongs at the tip of the needle. That's supposed to be provide you with little more chunk of tissue than just the cells, aspirating cells. Most of the time we do the slow stylet pull method that reduces contamination of blood rather than just aspirating with the syringe.
Are you going to use 22 gauge needle, or which needle are you going to use? Which
so this is
thickness?
a 22 gauge, 22
Gauge, yes.
gauge Acquire needle.
Okay.
What about autoimmune pancreatitis in this case? Autoimmune pancreatitis, maybe?
Yep. So as you mentioned, IgG4 negativity does not exclude autoimmune pancreatitis as well.
Yeah.
So that's one of the reasons I chose more of a core biopsy needle than FNA needles, which provides potential chance of staining, special IgG4 staining as well, and to look for plasma cells in tissue. So for the FNA, we'll focus on the target area. I think this one is a little more hypoechoic and a little enlarged. And before, we have to do power flow to make sure that there's no major arteries. I'm in a short position trying to aim for the superior portion of pancreas head. So typically, gastroduodenal artery comes into play around this area. If you nick the GDA, gastroduodenal artery, you're going to see bleeding for a while, make you really nervous. One more thing is this Acquire needle has a blunt stylet. So when you puncture, ready to puncture, you have to withdraw the stylet. On the right upper side, there's a needle stylet here. So I know exactly where my needle is coming out from. And making sure that I'm avoiding the big artery, which is kind of difficult to do. And to target to the area of the interest. I tend not to use the elevator, but this area, I I'm forced to use the elevator. So I withdrew the stylet, and once you determine, you put the needle in. Once needle is in, you have to take off the um, Doppler because it's gonna be in your way. Now this is a rather firm tissue, as expected. So I put the stopper here so that it won't go too deep, and I have to just penetrate much quicker. Oh, it may be a little bent.
Is it hard?
So it did not penetrate well.
Is it a firm lesion?
Yeah, it is. One of the other thing is I'm in a short position, so any force would put my endoscope backwards. So it does not translate to the needle advancement.
So any question from the audience?
Okay. So now we needed a really fast. Okay, so let's do clear. Push the stylet first, and then slowly pull back.
Norio, what is your position? There are a lot of discussions which needle to use, etc. Here in this case, we discussed that we also need to exclude autoimmune pancreatitis.
Yep.
What about your position of the 25 gauge needle in the pancreas?
Yeah, so 25 will give you a very small material. It's adequate for cellular evaluation. So I rather use the 25 for a difficult location. It's a much more fibrous tissue. I can feel gradual push. That's interesting. Almost feel like a serous adenoma type of feeling.
What is your position of using suction or not?
Yeah, so keep going, keep pulling, like a steady pull. If you suspecting autoimmune pancreatitis, I tend to use a 22 or 19 gauge core needle. And for difficult locations, we tend to use a smaller. Keep pulling. You have to keep pulling like steady pull. And for these special needle, you don't really have to do to and fro motion 40 times. I tend to do 15 to 20. And the benefit of the stylet pull is the reduction of the blood contamination.
Another option is to be a groove pancreatitis. Here we have many things for benign disease, maybe.
That's a good point.
Because we saw these cystic lesions in the duodenal wall, the pancreatic duct is not, it is dilated but abnormal. There is only some abnormal tissue in the head of the pancreas. And also the bile duct was like Caroli, not.
Yeah, the bile duct actually connects nicely into the ampulla, and on the imaging studies, we did not see the pancreas is wrapping around the duodenum. Would you have used a different type of needle?
No, I think this for this case it's very good decision for the 22 gauge needle. We were also discussing if this cystic lesion may be a form of pseudocyst. That would also possible because it always irritates us that there are such cystic areas within the submucosa. Or what would you say?
Yeah. So the one thing that's it doesn't really go along with the pseudocyst is this is much more lobulated type. It seems to be connecting through, and this location is within the submucosal layer. So it's very unlikely this is pseudocyst. Welcome back. So one of the key features I wanted to show you was liver parenchyma. It's a little bit echogenic, and liver edge is quite round. So we're suspecting that her alcohol consumption has a lot to do with the temporary elevation of liver enzymes, maybe alcoholic hepatitis. That goes along with the normalization of liver enzymes once she stopped drinking. Now the FNA sample was adequate. We're fortunate to get really good core materials on the cells. I mean on the slides, and the pathologist has evaluated the tissue, and I want to ask her to explain what she sees. Thank you.
Norio, you did very well, because this is a very tricky case, and somehow we are here in between the images, and also it's a good example how important the history is of the patient. So already in your introduction you explained well the history and also the laboratory results, and I think we can learn from this case how you described the technique of EOS, the description of the lesion, the FNA, but also then we are not only doing EOS, we also have to focus everything on the patient's history and then to try to make a diagnosis.
Yep.
But I think here we nicely saw it's a suspected lesion. We have to exclude malignancy, but what we have found sounds like a focal pancreatitis. But I think this patient needs also observation. How would you follow up the patient in the future?
Yeah, so we'll be waiting for the final path evaluation. Depending on the finding, definitely imaging follow-up is mandatory, making sure that we're not missing anything.
So we switch now to the pathologist.
Yes.
これは膵頭部から、採取された検体の厚座細胞診になるんですけれども、上皮成分はほとんど見られませんで、出現している細胞のほとんどは、リンパ球でした。血細胞や好中球は、あまりはっきりしていませんでした。で今後は組織診で、免疫染色等も追加しながら検討したいと思います。
Okay, on cytology, it seems that we didn't see any epithelial cells. Is that right? And lymphatic cells, infiltration, no plasma cell and neutrophils infiltration. Is that correct?
There seems to be not much. Is it active? Not much neutrophil seen on the slide. And
No neutrophils and
yeah, minimal neutrophil, mostly lymphocytic lymphocytes seen.
okay.
I raised the question if this could be a lymphoma as well, but she suggested to look at the slide in detail. We have some core materials and stuff from there.
So we'll wait for histology
Yep.
for the core specimen.
After to confess, there's a small bleeding happened after the FNA. So we wanted to do more sampling, but the safer is safety for the patient is better, the best interest. So we have a good material. We decided to just wait and see what that pathology shows, and we can add more FNA in the future if it's needed.
How many passes did you do?
I just did one, but
Okay.
on the glass, it looks like there's a fairly good amount of core tissue.
Okay. Thank you very much.
Thank you for your question.